Hello, everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director of Paltown, the nonprofit that supports Colontown. I organize DocTalks, which are Zoom video talks from expert clinicians from the field on topics that are relevant to colorectal cancer patients and caregivers. Today, we have Dr. Christopher Lieu with us. He's the Associate Director of Clinical Research and the Co-Director of Gastrointestinal Medical Oncology at the Colorado Cancer Center. He's also the Vice Chair of the NCI Colon Task Force. We're very excited to have you with us, Dr. Lieu, and he's going to tell us about ctDNA tests for cancer screening and about the CIRCULATE-US trial. Welcome.
Thanks so much, Dr. George, and thank you so much for the opportunity to talk to you all today about circulating tumor DNA in an upcoming trial or newly opened trial called CIRCULATE-US, where we're trying to utilize this new technology to change the way we treat earlier stage colorectal cancer. So thanks for taking the time. These are my disclosures. I do want to mention that there is a contracting agreement between Natera and my institution, University of Colorado. In regards to Natera, just mainly because they're one of the companies that produce ctDNA assays. All right, so what are we going to talk about over the next 30 minutes? We're going to kind of go back. So I know that you have already had great talks from Dr. Cohen and Dr. Kopetz in regards to circulating tumor DNA. And we're going to build on that, but we're going to take a little bit of a step back. So I'm sure you've talked about circulating tumor DNA or heard of it in terms of earlier stage or even the utilization of this type of technology in later stage colorectal cancer. But what about screening and primary prevention of colorectal cancer? And what we mean by that is essentially anybody who hasn't ever been diagnosed with colorectal cancer. We want to prevent those cases. So where can blood-based tests really make a difference? And so we're going to talk about screening just in general initially. And we're going to talk about screening rates within the United States. But we're going to then talk about where ctDNA may be appropriate in primary prevention of any cancer, but of course this includes colorectal cancer. And of course we want to follow up with a discussion about what CIRCULATE-US is in regards to the utilization of ctDNA for stage 3 colon cancer. So this is going to be a big kind of background that everybody already knows about colorectal cancer, because this group that's listening to this talk is you guys are really the experts. But it is good to kind of go back to the basics and talk about, what is the landscape of the epidemiology, the risk factors, and screening for colorectal cancer. And we know that this is the third most common cancer diagnosed in the United States. And the estimates for the number of colorectal cancer cases in 2022 are over 100,000 new cases of colon cancer and over 40,000 new cases of rectal cancer. So this is a tremendously big problem and certainly something that this group knows a lot about. And of course, the risk factors for colorectal cancer include risk factors for a lot of cancers, including being overweight or obese, having physical inactivity. A little bit different than a lot of other cancers is this idea that diet high in red meats, processed meats, or cooking meats at very high temperatures is a risk factor for colorectal cancer. And of course, these are some foods that a lot of people like a lot, So if you eat barbecue, it is a risk factor for colorectal cancer. And this isn't, an announcement to say don't eat barbecue, but of course it does mean that we certainly want to limit how many processed meats or red meats or high cooked or high temperature meats we eat on a daily basis. Smoking and alcohol use are significant risk factors for a lot of different cancers. But of course, we always worry about genetic risk and hereditary genes impacting our ability to develop a colorectal cancer. But this still is a vast minority of cases of colorectal cancer that have a genetic component to it. Familial adenomatous polyposis is only 1% of the population, and Lynch syndrome, which is the most common inherited cancer risk profile for colorectal cancer, is only 2 to 4%. So these are some really interesting charts in regards to the incidence of colorectal cancer by age. And so when you look at the population that's 55 and older, you can see these dramatic decreases in the incidence of colorectal cancer. And this really speaks to the power of primary prevention. This idea that if you screen for colorectal cancer, if you get a colonoscopy and remove polyps, you can really reduce the incidence of colorectal cancer. That's the big take-home message. But of course, this group is also very familiar with the fact that the incidence in our younger population. So what you're looking at here are graphs from 20 to 49. And you can see this inflection point in the 1980s and the 1990s, where the rates of young onset colorectal cancer really started to increase. And then it increased year over year. And of course, many of the people on this group and listening, and certainly the physicians and providers, would tell you that seeing young patients with colorectal cancer is really obviously still devastating, but it's becoming unfortunately more common. And so another way to look at this data is to look at colorectal cancer incidence rates by birth cohort. And you can kind of, again, see this inflection point that those born, kind of 1960 to 65 and then onwards, you can see this incidence increasing. Now, I do have to tell you that early onset colorectal cancer is, of course, still rare. But if it increases by 2 or 3% every single year, then you can tell that even though it's kind of still a rare event, it's becoming unfortunately more frequent. The United States is not the only country documenting an increase in early onset colorectal cancer, and those countries highlighted in red are showing similar trends. So this is a worldwide phenomenon and not solely restricted to the United States. So the first take-home point that everybody here already knows is that the incidence of colorectal cancer, particularly rectal cancer in young patients, is increasing. And this figure that you see here shows the duration of bleeding, of seeing blood in the toilet before diagnosis. And this is stratified by the stage of diagnosis. And so when you look at older adults, the onset of bleeding to diagnosis of cancer is usually about 25 to 28 days. Here, if you look at some of the patients that were diagnosed with stage 4 disease, on average, they were waiting over a year between the time that they had their initial symptoms and the time that they were actually diagnosed. And the longer that time takes, the more likely it is that you're going to have advanced colorectal cancer as opposed to an early stage colorectal cancer. So how do we prevent colorectal cancer? So, we don't always talk a lot about screening as oncologists because we're usually taking care of patients after they've been diagnosed. But the problem with this is that there's so many guidelines out there. It can be very confusing in terms of what patients should actually do. But of course, the American Cancer Society several years ago actually was kind of very forward thinking, right? And they actually decreased their age to start colorectal cancer screening from the age of 50 to 45. And I showed you the data as to why they wanted to change that. For people ages 76 to 85, the decision to be screened should be based on a lot of different factors, including how healthy that individual is. And the recommendation is that people over 85 should no longer get colorectal cancer screening. In terms of what tests that people offer, there's stool-based tests and there are visual tests, right? So the stool-based tests include looking for blood in the stool, and that's called a FIT test or fecal immunochemical test. We have the general fecal occult blood test, and there's even a stool DNA test, which we'll talk about. But of course, the gold standard is colonoscopy, because not only can you visually look at the colon, you can also remove polyps that may eventually turn into a cancer. There's also CT imaging that's available, and a flexible sigmoidoscopy looks at the first third of the colon, but of course cannot reach the last 2/3 of the colon. The United States Preventative Services Task Force also has guidelines. This is our most conservative guideline group because their expectation for the level of evidence is quite high. So they really, really look at the data and say, well, the data don't support certain screening, then they don't recommend it. But if it does, then they do recommend it. And so their grade A recommendation is still for adults aged 50 to 75. But the big update here in 2021 was a grade B recommendation for 45 to 49, which means that, again, these patients likely, they really should be screened. And of course, the more patients that get screened, the more we can prevent cancer. So your second take-home point, everybody should start screening at age 45 or 10 years before the youngest case in the immediate family. So if a first-degree family member was diagnosed at the age of 40, then you would start screening at the age of 30. Patients 76 to 85, just consider the patient's health, and a colonoscopy is the gold standard because it's preventative and potentially treatable as well. Just a quick note from Dr. George that if you guys have any questions as the presentation comes in, feel free to put it into the chat. In all honesty, feel free to just unmute and ask the question even as I'm speaking. Would love for this to be as interactive as possible. All right.
Dr. Lieu, then
Yes.
I have a question.
Sure.
So my question is, what about polyps, like polyps in the family, and how does that affect when you have to screen?
So it really depends on the type of polyp. And so it's such a great question because I think that this really gets overlooked. If you have your kind of typical tubular adenoma and you get those things clipped off, and then the risk of having colorectal cancer, from a familial standpoint is quite low. There's sometimes that patients have really really advanced polyps, basically these polyps that have really high grade dysplasia. And you can tell that, in the next 1 or 2 years, you can tell that that patient is actually going to develop a colorectal cancer. And that's why it's actually so critically important to know that if you have a very advanced polyp that has significant malignant potential, we should treat those patients as if they already had a colon cancer. So kind of complex. It's certainly one of those things that when you get a colonoscopy, you get a polyp removed, it is good to ask, hey, was it a really benign polyp or was this a really scary looking polyp? And if it's a scary looking polyp, then you go and tell your entire family. Great question.
Okay, thank you.
Absolutely. When you look at colorectal cancer screening across the country, there are disparities here, right? And so actually, one of the questions I really wanted to ask the group was, well, what is the biggest predictor, right, of getting, colorectal cancer screening? And and you'll find the answer as we kind of go through the next several slides. But is it race and ethnicity? Is it income? Is it even geographic distribution? You can tell that your rate of colorectal cancer screening actually differs by state, right? So if you're living in Texas, for instance, then the rates are 62%, which is obviously much lower than we want it to be. If you look in the Northeast, then Rhode Island, Massachusetts, New Hampshire, Maine, they have 75 to 76% screening rates. And the goal here is obviously would be 100%, but in all honesty, like even having 80% would be really, really tremendously impactful. And you can see that there's a difference across the entire country. Well, what about sex? So if you're male or female, does that make a difference? And here, there's a little bit of a difference between females and males, but for the most part is relatively the same and has stayed that way over time. What about age? So it does make sense that as you get older, there's increased use of screening. Maybe there's some other health factors. You're seeing your doctor more frequently, but it is interesting that as you go from 50 to 64, and then from 65 to 70, there is a pretty significant jump in terms of who's getting screened. What about race and ethnicity? It's interesting because I thought that the disparity gap here would be wider. It's not quite as bad as I thought there would be, but there is a disparity gap. And so even when you look at our Native American population and our Asian population, interestingly, those are some of our lower rates of screening compared to some of the other groups that you're seeing here. But for the most part, there isn't a huge difference. But what I'll tell you seems to be the biggest discrepancy or disparity between colorectal cancer screening and groups is actually your insurance status. And I think that that's actually one of the big take-home points is that if you're insured, you're going to get screened. And if you're uninsured or underinsured, only half of those patients are actually getting screened. So it does tell you that a lot of these things you can actually have an impact on, but it is kind of interesting data. All right, well, what about tumor DNA-based screening approaches for colorectal cancer? We're here to talk about circulating tumor DNA, and we're going to talk about, I see the question from Annie about right versus left-sided primaries and screening methods. So that's such a great question. And I'm actually going to answer that a little bit later over the course of the talk, because these tumor DNA-based screening tests, you want to make sure that you can detect cancer on both sides. Just to kind of go back to visual screening methods like flexible sigmoidoscopy and colonoscopy, if you have a left-sided primary, you should be able to see it on colonoscopy and flexible sigmoidoscopy. But because FlexSig only really looks at 1/3 of the colon, FlexSig is definitely going to miss the other 2/3, particularly the right-sided primaries, because you're just not looking. But of course, even with colonoscopy, sometimes you can miss the right-sided primaries because either the prep's not very good or, because it's just harder to get there. And sometimes you can't even get the scope all the way that far. So the right side is a little bit harder in terms of detecting cancer, even right with colonoscopy, but colonoscopy is still the best bet to find it. All right, I do want to talk about the first ever DNA test approved for use for screening, and that is a stool-based DNA test. So we talk about circulating tumor DNA, but here we're actually talking about stool DNA. And what you're looking at here are the performance metrics between the stool DNA test and fecal immunochemical test, which is basically looking for blood in the stool. And you can see across stages, the multi-target DNA test does seem better for early stage 1 and 2 cancer, and then performs about as well for stage 3 and 4. That question about left versus right is shown on the right side of this graph. And so proximal cancer would be the right side and distal cancer will be on the left side. And then you can kind of see that this test does perform better than the FIT test. And what's interesting about this is that you can actually even detect precancerous lesions with the stool DNA test. Obviously, it's not as effective in patients with polyps versus cancer, right? But you can tell that there's a certain amount of precancerous lesions that the stool DNA test is actually picking up. All right, and that gets us to circulating tumor DNA. So this
Dr. Lieu,
yes.
I had a question. So
Yes.
basically, they're looking for cells from the polyps that are shed into the stool. Is that what they're looking at?
So they're looking at DNA shed from the polyps into the stool. And so, you know, you imagine that over the course of time, these polyps have some genetic alterations. And we know that there's some early events, even like KRAS and NRAS and BRAF mutations are kind of earlier events in the development of cancer. But you can actually detect some altered DNA even in polyps. And you certainly can detect it in when there's a full-blown colorectal cancer. So it is interesting that some of the altered DNA you can kind of see in some of these higher grade polyps. Particularly, there's high grade dysplasia. They are shedding altered DNA that can be picked up by these tests, which is kind of cool, right?
Okay, thank you.
Absolutely. So, you know, again, I know that you've had lectures from Dr. Cohen and Dr. Kopetz in regards to what gets leaked into the bloodstream. And, you know, when you have a tumor that's in place, sometimes tumors can shed actual tumor cells that you can pick up in even sequence. They release these things called exosomes into the bloodstream, but when tumors undergo cell lysis or cell death, they do shed cell-free DNA into the bloodstream. Now, the way I always kind of describe this to my patients is that if you have somebody who's pregnant and you draw their blood, obviously a majority of what you see in the mom's blood is their own cell-free DNA. These are just cells, normal cells that are just turning over, and there's release of DNA into the bloodstream, which gets metabolized by your body fairly quickly. And so that represents a majority of the DNA that kind of floats around in the bloodstream. But a portion of that would be fetal DNA. So you can actually sequence out the baby's DNA from the DNA from the baby that's being kind of circulating around the mom. That also gets metabolized very, very quickly. Well, the same thing happens with tumors. So in our patients that have a tumor, a majority of the circulating tumor cell-free DNA in the body is that person's normal DNA, but there's a fraction of that can be circulating tumor DNA or ctDNA, which can then be sequenced and detected. And that's really kind of the basis of a lot of the technology that we're looking at. And certainly circulating DNA has its advantages. It's stable. You can actually do mutational testing on it. There are established biomarkers, and it's a short half-life. Why is that important? It's because a lot of times we get information from tissue, and that just represents one point in time. What's circulating in the body is happening right at that moment. So it gives you this real-time look of what's happening in the body at that moment. And there's the potential to do even further genomic characterization from the fragments of DNA that are released into the bloodstream. But of course, the disadvantages are the ones that are critically important, especially when we're talking about screening for cancer. So not all tumors appear to shed detectable ctDNA. And so we worry if a tumor is too small and is not releasing at least enough detectable circulating tumor DNA to capture in the blood, then you may at that point not be able to detect ctDNA, even though a patient does actually have cancer. The methodologies for analysis are really complex and expensive, and this idea that you kind of have to filter out a lot of noise. And so part of this is that noise can even be that as patients age, they develop these mutations that exist in usually in their white cells in their bloodstream that are not harmful at all and are not precursors for cancer. They're just kind of these altered mutations that are benign. But we call this clonal hematopoiesis of indeterminate potential, or we call it CHIP for short. And that is that sometimes as we age, we develop these mutations that exist in in some of our cells that are completely benign and have nothing to do with cancer. Well, what if we detect those mutations and say, oh, you have cancer? That would be obviously a real problem. So your take-home point, only a fraction of cell-free DNA is circulating tumor DNA, but ctDNA may provide a real-time look at what is happening in the body. And so there's a couple of points as we kind of go into this idea of utilizing a test to detect cancer for the first time. And so one of the things that people ask is, well, why don't we just use CEA, right? CEA is a blood test and a protein that we look for in patients with colorectal cancer. And sometimes we can trend CEA to determine if a cancer is getting better or getting worse, but is ctDNA better than CEA? And so what you're looking at here is ctDNA versus CEA positivity in different stages of cancer. And what I want to show you is that, particularly in earlier stage colorectal cancer, ctDNA definitely outperforms CEA. And you can kind of see that with ctDNA being on the left and CEA being on the right. You can see that CEA is negative in a lot of patients that actually have cancer. Whereas when you look at ctDNA for stage 2 and stage 3 colorectal cancer in particular, it's almost never negative, right? Which means that when it's positive, there's definitely cancer there. So I want to talk about 2 tests that are currently under investigation. One is colorectal cancer specific, and one is just looking for cancer, period. And there are companies that are certainly developing both of these right now. So this is a multimodal circulating tumor DNA test looking at the primary detection of colorectal cancer. This is called a LUNAR-2 assay. And essentially what both of these tests are doing are looking at something called DNA methylation. And aberrant methylation signals in tumor versus benign tissues are different. And so therefore, if you see kind of like this methylated DNA, you might be able to detect cancer earlier. And this is the test case. There were 434 cases, 271 controls, and this is the distribution by age in the controls and in colorectal cancer. And really what I want to show you is essentially this slide. What you're seeing here is the overall sensitivity for this assay for patients with colorectal cancer or without colorectal cancer. And you can tell that the overall sensitivity is unbelievably high, 91%. And in the age cohort 45 to 84, which is kind of traditionally the group that we're looking at to detect colorectal cancer, is 90%. And you're seeing this high sensitivity across stages, stage 1 and 2, stage 3. And then specificity is this idea that, if you detect cancer and if the test is positive and you do have cancer, what is the accuracy there? And it's 94%. So the key here is that, again, across stages, it's a really, really highly sensitive test. That's what you want in any good screening test. And then this question of left-sided versus right-sided, it's actually detecting cancers pretty well, maybe even slightly better on the right side versus the left side. And then transverse, there are not as many cases. There are only 17 cases of colorectal cancer, but it was 82% sensitive in that case. So a really, really interesting test. And I think this is really interesting early data. What they did was the company Guardant has a trial where they enrolled 12,750 patients to detect colorectal cancer. And we're hoping to get data in the middle of this year. And we'll find out what the performance of this LUNAR-2 blood test is in individuals that would normally be screened for colorectal cancer. And we're going to see how good of a test this is. But can you imagine, right, drawing a blood test to screen for colorectal cancer as opposed to, potentially either putting in for a stool sample or undergoing a flexible sigmoidoscopy or a full-on colonoscopy. So very, very interesting. And we'll see what the data is as they come out later this year. All right, well, so we talked about colorectal cancer. I just want to briefly touch on a multi-cancer early detection test. And this idea that can you utilize the same technology that we were just talking about, but look for all cancers. So imagine like a blood test to be able to detect any cancer and obviously, hopefully at an early stage. And so, we had talked a little bit about this before, but this focus on DNA methylation, the idea is to have a low false positive rate. And we call that, high specificity. And this idea that, if you have a lot of coverage over these methylated regions, not only would you be able to detect cancer, but if different cancer sites have a unique methylation pattern, then you could at least tell somebody, well, you may have cancer, we have no idea where it's coming from. You might be able to point people towards, well, this fingerprint is more suggestive of lung cancer or pancreas cancer or colorectal cancer. And that's what this really kind of complex figure basically shows you, is that you can draw somebody's blood, look at the DNA methylation, And then what they're really trying to figure out is there a tissue-specific methylation fingerprint where a specific methylation pattern might tell somebody, well, we really need to look for lung cancer or liver cancer or colorectal cancer. Because you can imagine as a primary care provider, if you just get this test back that says, oh, we think you have cancer, that's not only incredibly anxiety inducing from the patient standpoint, it's also incredibly anxiety inducing from the physician standpoint, because then they have, what do you do? Do you do a colonoscopy? Do you do a full body CT scan? And so you can see some risk involved with these tests as well. So this was a 15,000 participant study at 142 sites. And essentially what they had was a discovery group and a validation group. And essentially they wanted to see if the test could potentially work in a smaller group of patients and then look at a bigger group of patients. And these patients, some of them had cancer, some of them didn't have cancer. What this test kind of shows you is two take-home messages. Number one, the sensitivity is not great. It's 51.5%, which means in patients that had cancer, sometimes the test was positive, sometimes the test was negative. The other take-home point is that it was a highly specific test, which means that in patients that didn't have cancer, if the test was negative, they really didn't have cancer. And there are very, very few false positives. In other words, where the test was positive, but they did not have cancer. So it meant that basically the test was negative. There's an incredibly high chance that they didn't have cancer. And that's obviously a good thing. But the rates or the sensitivity rates across diseases range very, very differently, right? So you can clearly tell on the left side of this graph that this test is not a great test for prostate cancer, right? 11% sensitivity. That is definitely not ready for prime time. Well, what about colorectal cancer? Here, the sensitivity is quite good, 82%. And then if you go into liver cancer or even carcinoma of unknown primary, there the sensitivity is 93 to 94%. So it's a big spread. So is this kind of, is this the most, so I would say the data is very promising towards the right side of this graph, very not promising on the left side of this graph. And I think the main question that you have to ask is, well, will the technology get better? Can we get all of these sensitivity rates really, really high? So again, this is colorectal cancer sensitivity looking at stage 1 through stage 4. It's clear that as you go higher in stage, that the ability of this test to detect cancer goes up significantly. And it always seems like these tests have a harder time with stage 1, but the moment you get to stage 2 and 3 and 4, it gets actually quite good. And then I just wanted to kind of show you the detection of other GI malignancies. And there's really kind of one take-home message, and that is, for all these GI malignancies, it doesn't do great for stage 1, but as you get further into the stages, it does quite a good job of being able to pick up the detection of cancer. But again, the main question that you want to answer is, can this test save lives? And so we'll say, additional studies are needed. I think you're going to see this technology really change the way healthcare is delivered in the future. Right now, the question is it ready for prime time? And I would just say, we don't really know the answer to that quite yet. All right.
Dr. Lieu, I
yes.
had a question. So Exact Sciences had a large trial, right? Is that more like a multi-cancer, or is it more like CRC, the Guardant Health?
Yeah, so Colvera is really focused predominantly on CRC, although I know that they have data on other cancers as well. And it's kind of interesting because, a lot of these tests that I'm showing you are kind of casting this really, really wide net. Colvera is very interesting in the sense that they're really looking at 2 genes, right? But they found that those 2 genes really do a great job of predicting for colorectal cancer. So a little bit different, but kind of the similar technology.
Okay, thank you.
Absolutely. So I'll just wrap up on this with the last 5 minutes, because I do want to talk about, well, we talked about primary prevention of colorectal cancer. We talked about screening. Well, what about in patients that do have colorectal cancer? What happens to ctDNA in those patients, either post-operatively or even during surgery, post-operatively after surgery, but even during adjuvant chemotherapy? What happens to ctDNA? Does it go up? Does it go down? Does it become detectable? Does it become undetectable? And we call that ctDNA kinetics. And I just want to show you data from the Japanese group. This is their Galaxy study where they're utilizing ctDNA. And it's really interesting data. And what this shows you is that post-operatively, all the way to 12 weeks, if you're negative and stay negative, you're going to do great. That's the black line. And what you're looking at here is disease-free survival. Basically, nobody's recurring, right? So that's good. Interestingly, if you're ctDNA positive postoperatively and then you turn negative, that's almost as good as just being negative from the get-go. So that's interesting, right? If you're ctDNA positive postoperatively, you're freaking out. I'm worried, you're worried. But if you turn negative, then your prognosis is quite good. If you're negative and then turn positive, then there's a pretty high rate of recurrence. And if you're positive and stay positive, these are the patients that, here you're looking at almost 70 to 80% of those patients recurring, even within 1 year's time. And I do want to show you that adjuvant chemotherapy can clear ctDNA. So interestingly, there is a 10% clearance rate by doing nothing. And it makes you wonder what's going on in those patients. Are those patients just clearing it due to their immune system? But interestingly, there is a significant rate of patients that even if they're ctDNA positive, they receive adjuvant chemotherapy, they can clear it. We also know that if in patients that are ctDNA positive and they receive adjuvant chemotherapy, that they do better, right? And so that's what you're seeing in stage 2, stage 3, and stage 4, that if they're ctDNA postoperatively and they receive chemotherapy, that their recurrence rates are significantly less. So the real question that everybody in this group wants to answer is, are the findings of this test, which is very, very cool, but is it actionable? Because that's how we're going to save lives. So what do we know so far? If ctDNA is positive, the recurrence risk is extremely high. That makes sense. If we detect tumor DNA in the bloodstream, it means cancer's there. And it means that at some point it's going to show up on a CT scan. If ctDNA can be cleared, in other words, with adjuvant therapy, then disease-free survival is significantly improved. And we know that adjuvant chemotherapy can clear ctDNA. And we also know that if ctDNA is not detected, and it's not detected over multiple time points, we also know that those patients are going to do incredibly well. So this is the overall problem with stage 3 colorectal cancer, and that is that we're treating 10 patients with stage 3 colorectal cancer to save 2 to 3. And I'm going to kind of go through that. Why is that? In 10 patients that have stage 3 colorectal cancer, 5 of them are essentially cured with surgery. They never needed chemotherapy. In other words, they're getting treatment even though they never needed treatment because they were cured. There are 2 or 3 that get treated with adjuvant chemotherapy who relapse anyway, which means that we didn't help them with adjuvant chemotherapy. They were going to have recurrence whether we gave them chemotherapy or not. So we almost gave them chemotherapy needlessly. So essentially, we treat 10 patients to save 2 to 3, which means that we basically treat 7 to 8 patients needlessly with chemotherapy, either because they're going to be cured or because they're going to recur regardless. And so the idea is maybe ctDNA can tell us who we don't need to treat, and maybe we can tell with ctDNA who needs to be treated even more aggressively. And I just want to highlight this study because this study is now open to enrollment and is going to be open up across the entirety of the United States. And essentially, the way this trial is designed is that if you have stage 3 colon cancer and you have no ctDNA detected postoperatively, you are then randomized to receive standard of care chemotherapy, which is what we normally do, or surveillance without chemotherapy with serial ctDNA checks. If you're negative ctDNA and stay negative, you never get chemotherapy. But if you're negative and then turn positive, at that point, you get chemotherapy, and you get randomized to either receive standard of care chemotherapy or an escalation of chemotherapy where we try a 3-drug regimen versus a 2-drug regimen. And we do this because we're worried that our patients are, have a poor prognosis when ctDNA is detected. Postoperatively, if you are ctDNA detected from the get-go, you undergo that randomization, either to standard of care chemo or this triplet combination, which represents an escalation of chemotherapy. And so the real question is, is ctDNA ready for prime time? I would say in terms of identifying alterations in the bloodstream, that is ready for prime time. But what we're really trying to answer is, this bottom one. So in terms of the detection of minimal residual disease, the presence of cancer, even though we can't see it on a CT scan, the answer is possibly, is it ready for prime time? It's clear that ctDNA can detect cancer, but are the results actionable? And so the idea kind of being, we know that this is an incredibly prognostic tool. It can tell us whether somebody's going to recur or not. And we know that getting serial testing helps. But will it alter clinical practice? So what happens if you get a positive result? Do you increase surveillance? We don't know the answer to that. Will these tests save lives? So in other words, will a clinical trial like CIRCULATE-US end up showing good data in terms of, well, can we use this test to determine who should and shouldn't get chemotherapy? Can we use this test to determine who needs more chemotherapy? And I'm hopeful that we'll get the answer to that as time goes on. So I know that's a lot of information in a short amount of time, but happy to, I know Manju had to step aside for a little bit, but wanted to see if you guys had any questions. I see Julie has a question. Can you talk a little more about patient selection in CIRCULATE for stage 2? Yep. So if I was trying to keep it a little bit simpler, but Julie's asking a really great question, and that is the trial enrolls lower risk stage 3. So if you don't have a ton of lymph nodes involved, but there is this thing called high risk stage 3 if the tumor is aggressively kind of moving into other organs, or if a lot of lymph nodes are involved. There is also high risk stage 2, where there are features of the tumor that are really concerning for the clinicians. And that's usually related to how angry it looks under a microscope, or that tumor is actually invading into other organs. You can actually enroll into CIRCULATE if you get kind of outside testing, and that test is positive for ctDNA. You can actually enroll into the ctDNA positive arm. We just want to give those patients the ability to have a chance of getting more aggressive chemotherapy. So if you're high risk stage 2 colon cancer or high risk stage 3 colon cancer, you don't traditionally enroll into CIRCULATE. But if you have outside testing that you got kind of as standard of care and you're positive, then you can enroll. Annie's asking, the trial only is this location in NRG? Yes. So essentially, my hope is that it'll be open at more than 400 sites across the country. This is a collaborative effort between all the cooperative groups, which includes NRG. So this trial should honestly, it should really be open within, I mean, my hope is 30 miles from every patient. But the reality of it is that it should be open in every state and in most, if not all, major cities.
So in terms of, we have a lot of patients that come into Town who are, who would qualify for CIRCULATE-US, but they're not necessarily looking at clinical trials at that point because, they're not high stage, they're just recently diagnosed. Can you talk about kind of what that conversation could be in terms of how do they talk to their doctor about, hey, I heard about this trial, what is it interesting? Because the timing is they might be post-surgery, but adjuvant chemo. And so that's kind of good timing. So talk a little bit more about that, just because it's kind of it seems like a quick turnaround has to happen, but it's not necessarily people that are poised to have that quick conversation. So
yeah, I think the timing of this is the most challenging part of the trial. And that is this idea that if, most people get seen by a medical oncologist usually, a decent amount of weeks after their surgery. And capturing these patients early and getting ctDNA testing so it can inform, which arm of this trial you go on is critically important. And so, I think where Town and Town have been amazing is number one, it's a resource. So people are told they have colon cancer and, obviously, understandably, they're kind of freaking out. So I think the information that's provided on Town University is absolutely incredible. And then honestly, the earlier you can have the conversation, the better. So even before surgery, asking about it, is it available? Can I talk to somebody about it? Would be huge. Because then everybody's kind of knows, like as soon as surgery is done, that they're going to start thinking about the study, and they'll know whether or not it's even available at their site, or if there's a practice closer or within close proximity that they can enroll in. And so I think honestly, Town will find patients way before medical oncologists will. And I think just getting the word out would be really cool, because I think, but it's a tough conversation because people are just now getting introduced to this technology, and then they're talking about clinical trials, and it's kind of a complex clinical trial. So having that information available and even people to talk to, I think makes all the difference in the world for our patients, but can also help with a clinical trial accrual.
So would they would they connect then to the, let's say it is available at their location, would they connect then to the PI, or would they have ctDNA done before? How does that
So
work?
honestly, would connect either through clinicaltrials.gov, which would show the sites. Honestly, the easiest way to find clinical trials, and this is just in general, is to really ask, the doctors in that area to see if, because if they don't have Circulate open, I'm sure that they'll actually know who does. But then also contacting the PI, even like Dr. Dasari or myself, is always, I think, easy, because we'll happily direct people to the right place.
Great, thanks.
And then can either a signature or a reveal test qualify for high-risk stage 2? And it'll need to be a Natera test, Signatera.
I have an unrelated question, but
Sure,
it kind of drives me nuts.
Yeah.
So now we have a lot of awesome tools that are, using blood tests. Like, you can get your biomarkers from a liquid biopsy. You have ctDNA to detect whether, cancer, whether you have, MRD. But it gets really confusing in terms of what to call these tests if you don't call them by the brand name, So it's like trying to explain to a patient, like, oh no, that's a liquid biopsy, but it's a different liquid biopsy than the one, So is there like an easy terminology of like what to call these different tests? Because you say a ctDNA test, and some doctors still think, I mean, they don't necessarily, differentiate between the different tests. So anything that can help on that end, because it gets super confusing.
Absolutely. I think, and again, we're all learning this new terminology, right? And I would say, whenever you're talking about, is there cancer or not, we should just call those MRD tests or minimal residual disease tests. That's probably the easiest way. And if we're looking for mutations in patients with stage 4 cancer, we're just basically looking for, we wouldn't call those MRD tests or minimal residual disease tests. We would call them, I think maybe the easiest way to kind of describe it is almost like a liquid biopsy to look for mutations. That's essentially what you're doing. And so I think the easiest way to kind of think about it is, hey, if it's trying to determine whether cancer is present or not, MRD is probably the way to go. And then some questions. This is for rectal. Yes, rectal. Well, so CIRCULATE-US is only for colon cancer. Rectal cancer is a little bit tough because a lot of times patients are getting a lot of therapy even before surgery. In fact, they're getting almost all their adjuvant therapy before surgery. So the study is only for colon cancer, but these assays can be used for rectal cancer as well as colon cancer. And then Annie makes the mention that, for those over 70 with high immunoscore, I mean, I think the question is it only ctDNA? Could it be a combination of immunoscore and ctDNA? And I would love to see those collaborations in the future, because it may not just be it's one test to rule them all. Maybe it's a combination of different factors, right, to help us make these determinations. But we're starting with ctDNA, and then we'll have to kind of look how immunoscore may be added to this to help our decision making.
In terms of sensitivity, so we know this sensitivity is, really high for MRD tests, but there seems to be some things that tend to be more questionable, right? So lung mets, or maybe, location of mets if you're stage 4. And I know we're not necessarily talking about it in terms of stage 4, but, a lot of patients are doing it, or age, or things like that. So is there any kind of good understanding of kind of where, like within colorectal cancer, kind of how the sensitivity changes by either location of tumors or age or other factors?
Yeah, we had talked kind of about the age and the fact that sometimes patients have mutations that don't have anything to do with cancer. So that can be a confounder that we have to be very careful about. But then, this idea that maybe we're missing small lung metastases or peritoneal metastases where they're in the lining of the abdomen, I think that's what kind of keeps us up at night, right? And this idea that, are we going to miss patients that may benefit from chemotherapy, or are we just going to miss patients, period, that have cancer and we just can't detect it? I think we mitigate some of that by having serial testing, right? Testing that's kind of done over the course of time. And so if patients are negative and they stay negative, that's good. If they're negative and they turn positive, that's kind of what we worry about. But I think that therein lies the risk, right? We want these tests to be perfect, but no test ever is. And so, the question kind of being, is it good enough? And I think that that's what we're trying to answer. And then the testing is on site, right? I think for the study, they'll get collected by the teams, and then they'll be sent off. But oftentimes these companies do offer kind of at-home blood draws.
It is very compelling, I think, for patients from a trial perspective, and is in terms of cost. All those testing costs would be covered as part of the trial. Is that?
That's correct.
So,
great question, Julie. Yeah, that's correct.
This is about CHIP. So a test such as Signatera, you don't have to worry about CHIP, right?
Yeah, because it's a personalized assay, right? And I think this idea of kind of testing the tumor and then getting a personalized assay developed off of that really does help with some of the sensitivity. It really does.
Okay, thank you.
Well, guys, thank you so much for taking the time. These are phenomenal questions, and you guys are way more informed than even some of our practitioners, right? So it is so fun to talk to you guys, and you guys are asking all the right questions, and really appreciate your interest in this. And hopefully patients will enroll and they'll find it interesting. But the hope is that we're going to change the way we treat stage 3 colon cancer. That is the hope. But at the very least, we're going to learn a lot, and we'll do better, and we'll be better. So thank you guys. Really appreciate it.
Yeah. So I kind of want to say this, that like we will have the CIRCULATE-US as a featured trial in Colontown University. And our hope is that, patients in Colontown are, general CRC caregivers, and the patients in the public will be able to access it and find more information. So the video of this talk will also be linked there. So we are hoping that this will be a great educational resource for everyone involved. Dr. Lieu, thank you so much for your time, and this was excellent.
Thank you, everybody. Have a wonderful day.
Yeah, thanks everyone for attending. Take care.
Bye-bye.
Bye.